Samuel David Chandran, Assistant Professor, Department of Anaesthesia, CMC Vellore, sharing his thoughts about the airway in head and neck oncosurgery. Because if there's one place where there is absolutely no room for error, it is the airway. To keep them on track, we have our moderators, Dr. Rajiv Michael, Professor and the Head of the Department of Head and Neck Surgery, CMC Vellore, Dr. Satish, Professor, Department of Anaesthesia, and Dr. Leah Raju, Professor, Department of Anaesthesia. May I invite you all onto the stage.
So we welcome Dr. Sam Chandran for this talk, and he's been given the tricky challenge of keeping all of us awake post-lunch, but with an adrenaline-filled session regarding the difficult airway. Thank you, Sam.
Thank you, ma'am. Good afternoon, everyone. So, as ma'am said, I've been given the talk after lunch. I'll try as my best to keep you guys awake. So I was asked in a recently CME attended, they asked me what is the average attention span for someone who's listening to a talk or something. So there's a wide range of numbers thrown at the presenter. So I read up on it, and they say on average it's 15 to 20 minutes. So I'm going to try and keep it less than that so that none of you go to sleep. Okay? So my topic today is anesthesia and for head and neck and oncosurgeries. It's a tricky challenge, or should I rather say it's a twisted challenge. What are the objectives I want? So we're going to discuss airway challenges in supraglottic, glottis, and subglottic, and outline some securement strategies and also multidisciplinary takeaways. Coming to statistics, so the national audit project from NHS shows that almost 1/3 of major airway complications occur in head and neck or ENT surgeries. And a Danish anesthesia database shows that in emergency surgical airway procedures is 26 times more in ENT procedures. Coming to Indian statistics, I couldn't find anything pertaining to onco in Indian, but a general population says it's 9.7% for difficult laryngoscopy and 4.5% for difficult tracheal intubation. I'm sure if you extrapolate into onco surgeries, it will be a much higher incidence. So why is it tricky? Because it's a shared airway with the surgeons. It has to be a multidisciplinary approach, and also we have to anticipate complications during intubation and extubation. There are positioning challenges, and after this case, there's post-anesthesia recovery and airway support. So I'm going to do a 3-level assessment. I put some case scenarios for supraglottic, glottic, and infraglottic malignancies and some neck malignancies to help us understand a multidisciplinary approach to give the best care for patients. So the universal optimizing strategies, they say, is we need a good history of the case, a physical examination, NPL scope if feasible, important is radiological imaging, and discussion with the operating surgeons. A preoperative evaluation, a good evaluation should give us answers to these 4 questions always. So is face mask ventilation likely following induction? Is it going to be difficult or is it possible? Next, is the laryngoscopy or the intubation going to be difficult? Is awake technique more appropriate in the case given to you? And also we should always discuss with emergency, the surgical team, and be ready for a front of neck access if it's feasible in the given candidate. So a small 2 slides on RT, the effects of RT on the airway. So this is a study done which shows that the thyromental distance, there's a limited neck range of motion, Mullen-Petty scores all go up post-RT, which increases the challenge of securing the airway. There are certain things post-RT airway you have to be careful about. It causes fibrosis, and that can cause stenosis of the airway. There's tissue edema and inflammation, they're easily friable. There's reduced mobility. Also, this radiation pneumonitis. We've seen the increased incidence of bradycardia when the surgeons put the scope in post-RT patients. So going to the case scenarios, we'll start with supraglottic. So it's an occluding mass of the glottis, okay? So case 1, we have a 58-year-old female present with complaints of difficulty in swallowing for past 1 year. Diagnosed to have carcinoma supraglottis. She completed radiotherapy, bilateral vocal cords were found normal, mobile in NPL scopy. So this is the pictures of the NPL scopy. This is the mass sitting there. It is basically a smooth mucosa mass covering the laryngeal surface of the epiglottis. This is a radiological image. Okay, so how would we secure this airway? Would we do an awake fiber optic Would you do a video laryngoscope, or do you prefer a asleep fiber optic? So the patient here was asymptomatic. She could lie down supine. She didn't have stridor. So we went ahead. What we did, we thought we will go with video laryngoscope. So we induced the patient. We put the video laryngoscope, but we could negotiate the CMAC, but when we tried intubating, the tube we were not able to negotiate the tube beyond the glottis. So at that point, we put a Yonker suction. We railroaded a guide wire and railroaded AEC into the airway, beyond which we managed to railroad the ET tube through the AEC into the air, securing the airway. So what are the challenges in this case? So we can have difficult mask ventilation. The supraglottic mask can give us a ball valve phenomenon, wherein it can go close the glottis and open each time to ventilate the patient. As in our case, the reduced space for the scope. We couldn't negotiate enough to get a good view to intubate the patient. So the next case, another case, supraglottic recently did the case. This is a 43-year-old male, complains of breathing difficulty for 3 years, a voice change for 3 years. He had smoking history for 15 years. A huge bulge was seen in the soft palate on examination. This is the bulge. These are the images we got. So this was the NPL scopy showing the nasopharynx. Then this is after surgeons placed their thing. Radiology, you can see it's a mass fully occluding the airway. It was flush with the posterior pharyngeal wall and the tongue. So this patient had no. So what would we do? Would you do elective tracheostomy or awake fiber optic or video laryngoscope? So what did we do? We decided that patient was asymptomatic. He could lie down supine. He was not in stridor. So we decided that we'll do a awake look, a fiber optic look, and then decide to go ahead. So compared to the previous patient, this patient was able to lie down, but the mass was fully occluding. So CMAC was not the option at all here. Like the previous case I told, we couldn't put a CMAC here. But we kept the patient spontaneous, gave slight sedation for anxiolysis, and went to fiber optic. And we were able to go past the tumor, nasotracheal, and once we passed the tumor, the glottis was well seen. So we could go ahead and intubate the patient. Plan B was a tracheostomy in this patient. Next, we'll go to glottis, the rigid barrier. So again, one more case here is a 50-year-old male complains of voice change for 3 months, no breathing difficulty, 35 years of smoking. He had diagnosed of carcinoma glottis. So this is the NPL scopy showing. This is the mass on the glottic tumor. Again showing reduced airway. Okay. So what did we do here? The patient here was not symptomatic, was able to lie down. So we decided that we'll go induce the patient, paralyze the patient, and put a video laryngoscope and secure the airway with the MLT tube. But what are the challenges in glottic tumors? What can we expect? But again, this patient was lie down supine, no stridor. Hence, we went out with video laryngoscope. In glottic tumor, there's always a chance you can have complete airway closure with muscle relaxation, especially if both the vocal cords are not mobile due to the disease. When you relax the patient, there's a chance they can go for complete obstruction. We can always bleed, but when you touch the tumor, you can soil the distal airway or bleeding can occur. And tissues are friable. Another case for glottis is a 65-year-old complains of voice change for 3 months, occasional noisy breathing. On examination, he has mild stridor, occasional cough on drinking water. He is known systemic hypertensive. There is NPL scopy. You can see there is a glottic tumor. There's a mild subglottic extension also in this patient based on radiological imaging. So this patient, unlike the previous patient, he was symptomatic and he had a mild stridor. So in this patient, we decided that we'll go with awake tracheostomy and proceed. What are the signs of airway obstruction here? You can have any patient coming with cough on lying down with orthopnea or stridor or worsening dyspnea. These are your danger signs that patient can have having signs of airway obstruction. Your airway planning should be based on this. Okay, as I said, we ended with awake tracheostomy in this patient because patient was symptomatic and there was subglottic extension also. So we decided to go with awake tracheostomy in this patient. So again, in this patient, there's always a chance that you can lead to a can't intubate, can't oxygenate situation. You can have inability to pass the tube beyond the cords. So the last part is a subglottic. This is a hidden trap. Two cases here. So case 5, so it's a 55-year-old female, obese with papillary thyroid carcinoma. So she had a retrosternal extension and dyspnea on lying down, not in stridor, no history of voice change. So her trachea was deviated. This is the mass. Okay. So what did we do here? So she had dyspnea on lying down. So the plan A was here to do an awake fiber optic. So we made her slightly propped up. We did an awake fiber optic. We managed to get the tube across. And after intubation, we gave muscle relaxant, and her peak pressure increased to 40 centimeters of water. So immediately we put the fiber optic back through the tube and pushed the tube further in, which solved the thing. Plan B here would have been a rigid bronchoscope or a jet ventilation. So what are the learning points? So it's a mediastinal tumor, and there's something called landing zone. So when it comes to subglottis, always the tracheal compression is important that where your ET tube ends, it's called the landing zone. It should be beyond the point of your tracheal obstruction, because otherwise, if there's obstruction proximal to the obstruction, you will end up having difficulty in ventilation, your peak pressures go up. So it's always important to know the landing zone so that you are beyond the point of obstruction, so there's no problem in ventilation. This patient is low to intermediate risk. So here, if you have a tracheal with moderate symptoms with more than 50% tracheal stenosis obstruction, you fall in the intermediate. If it's less than 50%, more than 50% will be a high risk. So this is this is the last case. A 65-year-old male with complaints of cough since 8 months, occasional breathlessness since 8 months, MMRC grade 2. He had noisy breathing since 8 months, history of smoking, and on examination he had extensive wheeze. So on investigation, he is found to have a tracheal mass. You can see there. So it had a extra tracheal and intraluminal mass was there. So this patient had to get a biopsy for him, so he came. So this was taken up in the Pulmed theater. So we decided that we'll go on with the jet catheters because we inserted the jet. There you can see the jet catheter. So then the pulmonologist put a bronchoscope inside, and this is the mass actually. So initially when we jet, we could see the egress there. So that's when we were able to pass the jet catheter beyond the tumor. And since there was egress, we decided we'll continue jet. And they put the bronchoscope, and you can see the snare. So they tried snaring the tumor, but tumor could not be completely snared. So they decided they'll go ahead with deboring the thing so that the tumor can be taken out. So in the first sitting, they took some tumor out, and they actually stented and came out. Patient came out. So, and went back again in. You can see this is a stent there in situ. So initially we were extraluminal, then patients, they wanted more space. Then we intraluminal first. Then they wanted more space to work, so we put it extraluminal. We had to be dynamic based on the surgeon's needs. And after the stent was removed, second sitting, there's still a lot of granulation tissue. So finally, this patient ended up coming for a tracheal resection and anastomosis. But patient went back home walking fine. So here is plus plan. Important thing is that we plan to go jet ventilation. We have an automatic jet ventilator here. So so it gives a high frequency, low tidal volume. The importance of high frequency, low tidal volume is that your chance of barotrauma comes down. Also with these, the latest jet ventilators, they have pause pressure monitoring. So that's the pressure which is measured at the tip of the catheter. So when the pause pressure goes up, it will stop ventilating. This will prevent, basically it will make sure there's egress. If there's no egress, it will stop. So that will prevent barotrauma or air trapping, which is the protective mechanism of the jet ventilator. So those are the three different areas where you can see supraglottic, glottis, and subglottis. So what are the difficult airway guidelines tell us? So all of them have very good salient points. I've picked up just two, each have a small variability. Those alone I will highlight here. So IDA predominantly says pre-oxygenation is very important, along with head-up positioning, and nasal oxygenation during attempts. Para-oxygenation is very important, they say. And those guidelines, they stress upon using medial laryngoscope and maximizing the first attempt success in securing the airway. And ASA stresses upon limiting the attempts to 3+1 to prevent trauma. I'll go towards airway securement strategies. So I've put a pro and con table for this. I've chosen just 4 of the most common techniques we use. So first is fiber optic. The pro is it's a preserved spontaneous breathing. Patient's airway tone is maintained, which is helpful. But the con is it requires a good cooperation from the patient. Video laryngoscope, a good high first pass success rate is there, superior visualization. A lot of time now, because of video laryngoscope, we've actually stopped using fiber optic. A lot of video laryngoscope being used, especially D-blade makes a huge difference. But the con, there's always supraglottic masses, as we saw in the cases, there can be difficulty in negotiating the airway. And supraglottic airway devices, very quick insertion for a bridge, but the con, it can have some risk of aspiration also. The anatomy is distorted, it can have difficulty in seating. And jet ventilation is a very good tool, it's not bulky, good surgical access, and with a new thing, there's cons of risk of barotrauma pneumothorax also very reduced because the latest jet ventilators, they are very good, especially ones who measure pause pressures. So this is a recently published, last year published Italian journal, which gives us some algorithm to what we normally do. Is basically reimplying what we do. So for supraglottis, they say it's always look at the risk of collapse. If it is there, then you look at how much of laryngeal inlet is occupied. If it's more than 50%, they say do an awake tracheostomy. If not, you can do a nasotracheal awake intubation. These are guidelines placed there for us, but this should be applied to each patient you have, and slight alteration can be done based on the patient. And all guidelines should be taken with a pinch of salt so that we know to do the correct thing for the patient. This is oropharynx. This is for paropharynx. Again, if the oropharynx is occupied more than 50%, then you look at nasopharynx occupation. That also is more than 50%. You think about awake tracheostomy. But also, awake oral tracheostomy, oral tracheal intubation should be evaluated in selected cases with good mouth opening. If not, you have to go towards fiber optic. Okay, so that's what's the take-home message. Always see before you treat. Always before doing an airway case, see the NPL scopy, see the images before going in. Location detect strategy. Whether supraglottis, glottis, subglottis, you should know if it's kind of a ball valve phenomena, anticipate narrow bore by airway, always know that. Last is multidisciplinary stop moment. Before you go in, always discuss with your team, discuss the surgeons, have a plan A, plan B where everyone's on the same boat, so that even if you have to go to plan B, everyone's on the same boat, so the patient is in safe hands. I read somewhere in onco anesthesia, the most dangerous tool is not the laryngoscope, but the assumption that airway is patent. Thank you. These are my references.
Thank you, Sam, for a very comprehensive talk. So this is the one area where the surgeon and the anesthetist have to work together, because you're sharing the same airway, and what each one does will have huge repercussions on the other. So I have to have the confidence as a surgeon that my anesthetist will know what I'm capable of, and he has to know what I'm capable of. So when you talk about jet ventilation or an open airway, it's extremely important that each of us has a pre-treatment plan. If this goes wrong, what will we do? So when oncological surgery often means that certain things are not going to change. So if you have bad trismus, it's not going to improve sometimes. Sometimes it may improve with mouth opening, but you cannot assume that if it is due to oncological tumor extent. Secondly, tumors can bleed. So you can lose the airway at the drop of a hat, and you have to have a backup plan. So we have a certain degree of confidence, by God's grace. That person you saw with the big oropharyngeal mass, he's discharged today, by the way, no tracheostomy, feeding tube out, tumor resected in toto. So that's because of very good cooperation. If this man had had a tracheostomy, he would still be in the ward. He would not go home till the first 5 days. So that is the result of good coordination between anesthetic and the surgeon's team, and that's the cornerstone of head and neck onco anesthesia really. So the pre-anesthesia assessment is extremely important. So I have to be able to pick up the phone and tell Dr. Satish or Dr. Aparna that this is my plan, what is your plan, and vice versa. So that cooperation and your assessment is very important. So your Mallampati score, your thyromental distance, your neck girth, your fact that if cords are not mobile on the scopy. So now we have increases in technology. So you can have a narrowband imaging, you have optics better on scopy, so you can see your glottis. You have better dynamic CT scans. So these dynamic CT scans can show you the airway at real time as you go through the airway from the nose to the trachea. The only other thing I wanted to say is we are moving to an era where Thrive is becoming the standard of care. Thrive as well as its substitute like Strive HI, and these are extremely good because they give the ideal field is one where there's no tube, and you have the confidence that you can keep it that way and the patient doesn't go into trouble. Nice videos as well. Thank you.
Thank you, sir.
Thank you, Dr. Sam and Dr. Raju for the compliments. Actually, when the patient comes with a major head and neck tumors, first clinical symptoms are very important. This particular case, when the CT shows no airway from nasopharynx to oropharynx, but the patient is comfortably sitting, lying and eating, drinking. So then we thought, why can't we do awake and have a look rather than straight away go for a tracheostomy? Then the awake look, we could easily bypass the tumor and get the airway done. So that clinical acumen and planning is very important, but the same thing we need to discuss with the surgeon also. This is our plan. If surgeon says, no, you cannot negotiate, you should give respect. You should not just go with the heroism and create trouble. So it is a multidisciplinary coordination, and sometimes patient may not be very cooperative also. Patient may have some irritability, cough, and they may be more anxious. That time some sedation we need to carefully titrate and get the work done. So I hope this case scenarios will give an overall idea. So sometimes we may go out of the guideline, but this comes out with the confidence of doing many cases and our gadgets available in our system and the surgical backup. Thank you.
Any questions from the house?
Yes, ma'am. Yes, we can go with hybrid tumors. We have used it here before. Virtual, no.
You mean CMAC with fiber optic?
Yeah.
Yes.
The case what you showed, which you used anchors, I thought we could have this.
Yeah, fiber optic, and we have done it, but this recently this anchor suction, previously the anchor suction surgeons only will use. Once when I used it, I could move the tumor a little away and I can see the cords. So then I realized with the CMAC I can move the tumor with the anchor and put the tube in.
So actually,
keep the anchor in and oxygenate and then subsequently pass a guide wire or AEC catheter.
so there's an article on it where through beyond anchors they have put a bougie and then they have done it also. So another thing what I wanted to ask you, do you use fiber optic for all your huge thyroids? Because what you did with fiber optic, after that you put the tube, your airway. So if you would have just done video laryngoscope, because it is beyond vocal cords, till vocal cords your airway is okay. So is it always you use fiber optic or sometimes you do?
She was not comfortable lying down at all. She was very dyspneic on lying down, and also it's a huge retrosternal extension also.
So how did she allow you fiber optic? Did you
So
sedate the patient?
we kept her sitting position, and we did from front of patient we did access. We gave slight sedation of anxiolysis, so she's a little spontaneously breathing. She was not supine, she was almost sitting. So once we secured the airway, then only we relaxed her, and once we relaxed her, only we realized that the paw went up. So then we immediately again put the fiber optic and decided that landing zone was further down, so we pushed the tube. Because she was very dyspneic, we decided that we'll do a awake fiber optic, began retrosternal extension of the tumor also.
So I would sometimes I would just do video larynx, just put the tube, give the relaxant, then put the fiber optic and see. But if the patient is not cooperative.
Can lie down 30 degrees is okay, but she is unable to
Lie
even
down.
45 degrees. So that's why in this case we processed. Most of the time thyroid,
Yeah.
most of the time thyroid, we just paralyze and intubate and push the
That's
tube
what.
till down.
Now, another thing is the narrowing. If it is very much and you put the scope, have you ever had any situation where they became restless because your scope closed the opening with what he was breathing? Because cock and bottle phenomena. But that is what I was thinking. Like if you're feeling.
Patient, it is a flattened anteroposteriorly and sideways there is opening. So there is not blocking that. But in a vocal cord tumor, sometimes we get 3 millimeter aggregate, where if you plan for a fiber optic, the patient may not allow. By the time you go, the patient push out. So those cases nowadays we do CMAC with the short-acting scoline. Just push the tip. And surgeon also say, you do little bit degrowing, I will do the full degrowing.
And whatever way we secure the airway, if it is subglottic, we will touch it any which way.
Yeah.
So that is another thing. And in thyroid, remember, like if the tumor is posterior, it will not expand. It's because of that. So sometimes the tracheal diameter is 3 millimeter, 4 millimeter, but our tube goes 7 sides.
7.
But if it's a posterior tumor, it will not expand.
It'll be fixed.
So that is one thing all of you should
Sure, ma'am.
this thing. You were asking something.
Just one more learning point for the juniors. We have to remember to consent our patient to all these likelihoods. It cannot be explained for the first time post-procedure. None of us would accept that, and I don't think in this era people would as well. So remember to explain all possible scenarios, not to frighten them, gently with a firm tone as to what the possibilities and how you would keep their safety in mind.
Do you do virtual bronchoscopy for these that supraglottic tumor that you had showed, no? Almost where you said the patient didn't have any obstruction or symptoms. Where you had.
First
do
we.
you think it is helpful? Virtual bronchoscopy. They do the reconstruction.
We tried, but only thing is it is a dynamic process. They are not able to give a dynamic broncho. So finally it looks like totally obstructed. But the patient is asymptomatic. So you should take with a little pinch of salt. Same thing, the CT also, we thought of doing a study with the dynamic CT, how much it is during the inspiration-expiration variation. The radiologist could not give a much difference. So that's why we awake fiber optic assessment by yourself makes more better assessment rather than depending on this virtual bronchoscope.
Then you have to have the time to have done that. If you are doing a dynamic CT, the patient should be cooperative and you should have the time to plan that procedure.
So I would add to it that virtual bronch, it helps us when we want to see beyond the tumor.
Yeah.
If the airway is good. So if you do virtual endoscopy, like if you had a plan and you do virtual endoscopy, we just did some larynx cases and we realized our plan changed after that.
Okay.
So it's not dynamic because they are only taking the CT scan imaging that 1 or 2 millimeter from the CT scan. But it is like everywhere it is there. If any case, if you are doubtful, just get it done. It adds to it. It may not, but it has its own things like the mucus plug may look like a tumor.
Yeah.
It has some of its things, but it
It
is
helps.
helpful.
It helps. Okay.
I mean, whenever doubtful, one doing
No.
will not harm.
We
It may not
definitely.
have too much advantage, but the best would be to do a pre-op check bronchoscopy.
Yeah.
And I like 90-degree scopy the best and pre-op check. So it gives me subglottic also, it gives me supraglottic.
Supraglottic
So
also.
that is two things is.
Thank you.
Thank you, ma'am.
Thank you, everyone. Thanks, Sam.
Thank you.
But since this was a post-prandial session, it's a 30-minute, he kept us engaged because we are all holding our breaths, tube is going in or not. So as a mark of reward, we thought we will invite most of you on June 14th to Adyar Cancer Institute. We are going to hold a one-day workshop, both pre-prandial and post-prandial.
Sure, sir.
So we will give you the information a little later, but I take this opportunity and thank Amit to get us over here. And I thought we'll just give this information and we'll reach out. Because dealing with this with experts from all across, we should put together a program where they can get more hands-on experience. And this is just a precursor. Thank you,
Sure.
sir.
Thank you so much, sir.
It was definitely not a talk that we could doze off to. I request Dr. Rajiv to kindly give the memento to Dr. Sam.